Good morning, everyone. I would like to thank the organizing committee for this very nice opportunity. My name is Alessandro Volpe. I'm a urologist, and I will give you in the next 15 minutes an overview on ablation techniques for small renal tumors. We all know that small renal masses are increasing, that they are mostly incidentally detected, and that in the majority of the cases have a very low malignant potential and harbor a low risk of progressing to metastatic disease. When we deal with treatment decision-making for small renal masses, we are all aware that cancer-specific survival is excellent and generally similar between treatments. We know that overall survival is mainly determined by deaths from competing causing, and that therefore the impact on renal function, complication, and quality of life play a pivotal role in treatment choice. There is no doubt that partial nephrectomy is the gold standard for management of small renal masses according to all international guidelines, since it provides excellent oncological outcomes while minimizing the risk of progression to significant chronic kidney disease and potentially benefiting in terms of overall survival and reduction of the risk of cardiovascular events. However, for each individual patient, we have to take into account, besides tumor characteristics, also patient characteristics. And we have learned over the time that patients with advanced age, significant comorbidities and short life expectancy, advanced chronic kidney disease, of the preference to avoid surgery, can benefit from viable alternative managements, including tumor ablation. When we look at what the clinicians that perform ablation, the so-called ablators, say, mainly interventional radiologists, we can see that they tend to define percutaneous ablation as an alternative to surgery for all clinically T1A RCCs, although they recognize that the best patients are those we have mentioned before. When we look, on the other hand, at urological guidelines, the indication seems to be less wide, and generally they are limited to smaller, less than 3 centimeter renal masses, and all guidelines clearly mention the higher risk of local recurrence with ablation techniques. There are several modalities for tumor ablation. Some modalities use low temperature to kill tumor cells, mainly cryoablation. Others use high temperatures, radiofrequency ablation, microwave ablation, and the experimental high-intensity focused ultrasound. And then there are non-thermal modalities, such as irreversible electroporation. Of those, cryoablation and radiofrequency ablation are by far the most widely used. Cryoablation relies on low temperatures, below -40 degrees, to induce cell death. Argon-based cryoprobes are stuck into the tumor to cool the cells through the Joule-Thomson principles. They create these ice balls. Tissue destruction occurs through both freezing and thawing, and generally a double freeze-thaw cycles is used. The mechanism of action is based on direct injury of the cells by formation of ice crystals, coagulation of vessels causing ischemia and cell death, and induction of apoptosis through immunomodulation pathways. Radiofrequency ablation, on the other hand, relies on radiofrequency energy that creates tissue heating. High-frequency alternating electric current delivered by umbrella-shaped probes like this one induces oscillation of ions within the tissue. Ions oscillation results in molecular friction and heat production up to temperatures of 60–90 degrees. That induces protein denaturation and cell membrane collapse and disintegration with coagulative necrosis of the mass and cell death. Microwave ablation causes cell deaths in a similar way to RFA, but with a distinct mechanism of cell killing. Microwave bands from 1 to 2.5 gigahertz causes polar molecules like water to realign, and the realignment of water molecules increases the kinetic energy in the tissue, resulting in heat production. There are some advantages of microwave compared to RFA. First, heating in this case is independent of tissue impedance. There is a continuous heat generation in larger volume that allows the treatment of larger renal masses, and tissue necrosis is achieved in a shorter time. On the other hand, there are some disadvantages. Penetration and heat production depends strictly on water content, and the ablation zone is related to the antenna design. Finally, irreversible electroporation is a non-thermal modality. It delivers electrical pulses to ablate tissue, and these high voltage electrical pulses generate an electric field that causes holes in the cell membrane, the so-called nanopores. The irreversible formation of nanopores increase cell permeability and induces apoptosis and cell deaths. There is very limited literature to date on this treatment modality. When we look at technical consideration, all these ablation techniques can be done with a laparoscopic assisted or a percutaneous approach. The laparoscopic assisted approach was mostly used for cryoablation. It allows an accurate puncture of the tumor with cryoprobes under direct vision. But on the other hand, it requires general anesthesia, longer stay, and higher costs. The percutaneous approach can be done for all techniques, is really minimally invasive, can be done with ultrasound or CT guidance, with sedation as a same-day procedure. So the percutaneous approach today is minimally invasive and is the way to go. Studies compare the laparoscopic and percutaneous approach, for example, for cryoablation. And as you can see here, the mean length of stay for the two approaches was shorter for the percutaneous approach. Complication rates and decline in renal function were similar, and the oncological outcomes actually were mainly influenced by baseline patient or tumor characteristic and not influenced by the ablation approach. A systematic method has been developed by International Society of Interventional Radiologists to review cross-sectional imaging of renal masses. It's called the Ablate Renal Ablation Planning Algorithm. It helped to anticipate and manage potential technical challenges of ablation to maximize the oncological outcomes and minimize the complications. According to these statements, if the tumor is larger than 3 centimeters, like those represented here, the best approach is cryoablation, while microwave ablation is a possible alternative. When the tumor is very close, less than 1 centimeter to the colon or small bowel, the patient should be repositioned, or gas or saline should be injected in order to displace bowel and decrease the risk of colonic injuries. Of course, tumors in the posterolateral aspect of the kidney are the best candidate for ablation. However, also anterior tumor can be ablated, also in the right side, as you can see, with the treatment success of this complex lesion. And even a transhepatic approach can be used in expert hands in experienced centers. When the tumor is close to the renal sinus fat, there is a risk of it sinking, especially for those techniques that use heat. And also there is a higher risk of damage to the collecting system. For all of these reasons, cryoablation should be favored in these conditions. Finally, when the tumor is fully endophytic, like this one, the ablator should consider to use contrast-enhanced ultrasound to better localize the tumor and increase the probability of treatment success. All guidelines recommend a renal tumor biopsy prior to ablation to confirm malignancy, to better characterize pathology, histotype and grade, and to guide surveillance after ablation. There is a consensus for the use of 18-gauge needle for the biopsy, and the coaxial system should be always preferred to reduce the risk of seeding. The biopsy can be done some days before the procedure or in the same setting, and most interventional radiology prefer to do it the same day. However, it would be much better to perform it a few days before in order to use pathology information to really make the best treatment decision making. In my opinion, high-grade RCCs at biopsies are not the best candidate for tumor ablation in any case. The complication rate of ablative techniques is not very high. In this large analysis of the complication rate of cryoablation, you see that the rate of complication was 8 to 13% with a percutaneous approach, increasing to 20% with a laparoscopic assisted approach, but most complications were low grade. That means that they not required operation after ablation. Tumor size, location, and medical comorbidities are important predictors of complication. Some patients, about 9%, experience a post-ablation syndrome, basically fever and flu-like symptoms. Bleeding is not very infrequent, but in general, it just leads to a formation of hematomas that are not clinically significant, while the transfusion rate is very low. And then we have non-target terminal injuries that can be injuries of the ureter, causing urinary fistulas or urethral obstruction, colonic or small bowel lesions, causing perforation of fistulas. And in these cases, we have heard either dissection or dissection with saline should be used in order to displace the bowel. And there can also be damages to the genitofemoral nerve, to the psoas muscle, or the adrenal gland. The risk of tumor seeding is, of course, another important caveat, an important complication that should be avoided in any case, while infection and pneumothorax are rare complications. Success of ablation is generally measured radiologically by the assessment of the lack of contrast enhancement. And in general, serial access CT or MRI are used during follow-up. However, unfortunately, the definition of technical success and efficacy is very variable and not standardized. And we have to remember that technical success and efficacy differs from long-term positive oncological outcomes. Also, surveillance schedule and length of follow-up are very variable and not yet standardized. However, there is an effort, again, by the Society of International Radiologists to improve and better standardize the definition of progression, technical success, and efficacy in order also to improve the reporting, the scientific reporting on these ablative approaches. When we compare ablative techniques, and again, cryoablation and radiofrequency ablation are the most widely studied, both approaches have shown excellent technical success rates and similar overall complication rates and oncological outcomes. Cryoablation seems to be less harmful to the renal collecting system. It allows monitoring of the ablation with ultrasound real time during the procedure, and is potentially more effective for larger tumors. On the other hand, radiofrequency ablation correlates with a shorter procedure time, with a lower risk of bleeding complication and lower costs. However, unfortunately, this is all based on retrospective on small comparative trials and no randomized controlled trial as this comparing these techniques. However, we have data from the literature from retrospective analysis showing that either cryosurgery and thermal ablation actually have better overall survival probabilities than deferred therapy, that means active surveillance. Although, of course, in all serious patients who are enrolled in active surveillance protocol have a significantly worse comorbidity profile. Of course, one of the most important questions is whether ablation can be compared to partial nephrectomy for small T1A renal masses. If we look at the largest meta-analysis in this field, we can see that actually perioperative complications favor tumor ablation. There is no significant difference in postoperative change in renal function between surgery and ablation. Cancer-specific survival is not different. However, the local recurrence rate is significantly higher after ablation, and also the overall survival favors partial nephrectomy, although this is in part due, of course, to selection bias. This is regarding T1A renal tumor. What about larger T1B renal masses? Well, the current evidence is limited. limited series, small size, and so the evidence is very heterogeneous. However, it seems that cryoablation and microwave ablation yield the best opportunity in these cases. However, we have to take into account from SER data that unfortunately there is a 2.5-fold increase in cancer-specific mortality in patients who undergo cryoablation for a T1B renal tumors compared to those patients who undergo a partial nephrectomy or anyway surgery for this kind of lesion. And this is a strong message and actually should lead to the use of cryoablation only in clinical trials or institutional protocols for T1B renal tumors. As the EAU RCC guidelines panel, which I had the honor to be part of, actually came out with some recommendation on tumor ablation. We reviewed all the systematic reviews in the literature, and we observed that they all had low confidence rating, with all but 2 actually being rated critically low. And therefore, we came out with a statement that tumor ablation may be cautiously considered as an alternative to partial nephrectomy for clinically T1 renal masses. However, patients must be counseled carefully regarding the prevailing uncertainties. Can we have further information? Well, further very useful information would come from randomized trial comparing ablation with partial nephrectomy. However, if we look at clinicaltrials.gov, we see that there are only 2 trials actually that actually closed recruitment in 2015 and were never published. So unfortunately, we have no answer. And also UK group tried to design and run a trial comparing ablation with surveillance. They screened 150 patients, 36 were eligible, only 6 were randomized. And so due to patient and physician choices, due to organizational issue, actually they came out with the conclusion that a trial like this is not easy to do and probably even not possible at all. So to come to a conclusion, cryo and radiofrequency ablation are the most widely used and studied techniques for ablation of renal tumors. A careful patient tumor selection is mandatory to optimize efficacy of this approach. These approaches have definitely favorable perioperative outcomes, and they have also similar functional and oncological outcomes compared to partial nephrectomy for small renal masses. However, the quality of the evidence is very low, and strong messages are not possible. Ablation is definitely less effective than partial nephrectomy for larger renal tumors, and we have limited data in this field. So at the end, tumor ablation is clearly a valuable option in elderly and comorbid patients with small, less than 3 centimeters small renal masses, while wider recommendations are today limited by the lack of solid comparative data compared to surgery. Thank you very much for your attention.